Hey everyone, welcome back. We're talking about chronic peroneal tendon pathology, something that can bother a lot of our athletes for quite a bit of time because it can be misdiagnosed so often. Eric Giza is going to provide us with some of insight, moderating this next session with an esteemed faculty. I do want to thank Alifair Biosciences for sponsoring this hour. Eric, it's all yours.
Thank you very much. The peroneal tendons are like, they always seem like they're simple, but it's how to approach it, especially for the chronic ones. It's easy when someone comes in and they say, hey, I just had an ankle sprain and, they pop their peroneals. But I do want to say, I want to thank Dr. Selene Parekh. We've had many great times and many great academic ventures over the years, and we'll have more. So I have an esteemed panel, and I'm really happy to have my colleague, Dr. Gregg Lundeen, who we share a fellowship with, Kirstina Olson, who's at UCSF, my partner, Dr. Chris Kreulen, and Kaitlin Neary, who couldn't be here tonight, and it's kind of a combined effort between her and Kirsty presenting. So I'm just going to give a quick overview. We know that the peroneal tendons are, their main function is eversion, and then of course plantar flexion of the first ray for the longest. And so these are two different distinct tendons that have different distinct ideals, but for a long time it was all just, anastomose them. So they're dynamic stabilizers. We know their origin, but it's kind of a funny tendon because you think about it. You have the brevis that just goes to the base of the fifth metatarsal, but the longest goes all the way under the foot, and plantar flexus is the first ray, and it has a distinct, thing to do. So zones of injury, we have to think of whether this is just above the fibula, et cetera, or down at the cuboid tunnel with the longus. And there's, when I was a resident long time ago, the thought was always like, was this part of how we think about posterior tibial tendon disease? But it's not. And this was a nice study showing that there really isn't this watershed area to the brevis. So we have to think about things over the next hour as we talk about the solstice, the tubercle, where are the different places of pathology for these tendons that are so important, and then the retinaculum itself. I mean, it's really a dynamic retinaculum. It's associated with the Achilles. Do we just cut through this thing? And we all know that it's very difficult because it's a unique osteosynovial covering that is you have the back of a bone that has a tendon running through it. And then it comes down, and then people, I feel, usually, ignore the IPR, the inferior peroneal retinaculum. And look at this. That's where the tendons get trapped often. And this is just, doing a little release of these at the IPR, because when they get, synovitic or tenovic, they get caught. So people think they can just tubularize the tendon. And then this is the best thing. And I'm really looking forward to this with our panel, because one of my good friends, Professor Tumai from Japan, basically kind of showed that the back of the fibula is more like the whole thing about shoulder instability, the glenoid, the labrum. That do we really need to do a groove deepening? And we'll see what the panel has to say. But most of the time, it really isn't. And then there's a cuboid tunnel. So there's so many different aspects to this tendon pathology that we have to think about. And there's always a thought about all of this. So here we go. So let's hear from the panel. And I think Kreulen's going to kick us off with the latest and the greatest. I'm going to stop sharing. And he's going to tell us about doing this all with the scope.
All right. Everything, you can see it, you can hear it.
I'm hearing and I'm seeing.
Perfect. Okay, so I'm going to briefly talk about peroneal tendoscopy. I'm at the University of California with Eric Giza, and we do some of this together, and I'll briefly go over it. So just to review some causes of chronic injury of peroneal tendons. Chronic ankle instability is typically a very common reason for peroneal pathology, but we also know that people with cable varus hindfoot deformity or a metatarsus adductus is another reason for chronic peroneal problems. And also you can get overuse, and then Eric Giza discussed stenosis a little and had some interesting videos there. So again, the zones of injury primarily see in zone 1 and zone 2. And sometimes we don't know if the injury goes from both of them or if it is stuck in just one area. Typically, we use MRI, and you can see the axial images showing the peroneal tendons in the back behind the fibula. And then sometimes you can see what some people will say the brevis tear is, this Mickey Mouse or tie wing fighter sign. So you could see again here, increased synovitis, swelling around the tendons. You know something is going on. There's probably some pathology. We did a study here years back and looked at the positive predictive value of the peroneal tendons, and just showed that the MRI wasn't necessarily always as accurate as we thought. So other people have started to push ultrasound, and they show a very strong sensitivity and specificity. I myself don't even know how to use an ultrasound, so I rely on some of our colleagues in the sports medicine department to do it for us. But the thing you can do instead of ultrasound, or say someone has ultrasound and you're going to go to the operating room, is you can use peroneal tendoscopy as your tool. So sometimes you can't get ultrasound or someone can't get an MRI. So this is also a very helpful tool, but you can use it to diagnose patients who have pain in the peroneal tendon region, and they may not have an MRI, or maybe you don't even see a tear on the MRI, but you want to go check it out. Instead of opening up the whole length of the peroneal tendons, you can use peroneal tendoscopy to allow for it to be done in a smaller, less invasive manner. So quickly, some of the indications: synovitis, brevis tears or longus tears that are small. Maybe you need to diagnose some mild subluxation, or they have low-lying muscle that's causing impingement. There have been a few articles looking at tendoscopy, and obviously the ones that were published showed that it was successful. Now, Samarco has a good article helping describe and teach you there's 4 distinct zones that you can use to debride and evaluate. Here's how we set it up. First, you put the patient lateral. We hold them in that position with a beanbag, and then you drape their leg over some blankets, but you have the blanket stop short, probably more at the medial malleolus, so it allows for the foot to invert and allows you to manually evert it, so you can manipulate the ankle much easier instead of having it held in one position with blankets under the foot. Now there are some landmarks that you have to mark out: the fibula, the base of the 5th metatarsal. Can you palpate both the brevis and the longus? And then where is the peroneal tubercle? And then there are 3 main portals: the inferior, the middle, and the superior. First, from the superior portal, you would inject saline down into the sheath to try to expand it, similar to what you do with an ankle arthroscopy. Then you can introduce the arthroscope from the middle portal, looking upward towards the superior portal. This is a very easy area to identify the peroneal tendons, and therefore you can assess the tendons. In this video, see if it plays. Here we go. We'll show, here we are with the trocar manipulating the tendons, and you can see there's a tear right there. So it's helping you identify exactly where the tear is. Let's see. Maybe I need to do that. Sorry about this. All right. So now you can move the portal, the arthroscope superiorly and look down, and you have a much better idea of where you're at. Now you can see the fibular groove. There are your two tendons, and there's that tear that we were seeing earlier. And then you can use your shaver and you can debride this. So you might not even need to open. You can do a lot of this through the portals. Clean up some of that synovitis. And then you can look down and evaluate that fibrocartilage SPR and see if they are holding the tendons in position in the posterior. And then this is a video showing this subtle laxity. The patient was having pain. The MRI didn't really show much, but as you start to stress, you can see that that SPR is not really holding the tendons there. So in an athlete, they're very finely tuned. They're going to feel that laxity. And so you can go in and you can fix that. Now, finally, here's a picture of the arthroscope. And then you can see next to it is a nanoscope. So these flexible scopes that people are starting to create. This one is a 1.7, and it's a lot longer, as you can see. And it allows for you to bend in the length of the peroneal tendon sheath. Some people would critique that it just has a 0 angle on this camera instead of 30 degree like a normal arthroscope. But other people found it very successful, and it's also a little bit smaller.
You can see the advantage of the
Hey, Chris,
setting.
Chris,
Typically,
I don't think your
you're going
slides are progressing.
Whatever.
going to presentation mode.
I was in presentation mode.
All right. All right.
What do you want? Is this better?
Yes.
Okay, so it doesn't need to be in presentation mode.
In Kreulen.
It never works when I do this, Selene. So here are the two compared to each other, if you heard me from the past. All right, so now our sponsor is Allofair. So I would just like to say that we use Allofair here at UC Davis, and we use it with a lot of our chronic injuries. And we found that we think it helps decrease scarring and improve the healing environment. So right now we're in the current study evaluating this and seeing how our patients do. So in an arthroscopic manner, if you are just debriding and cleaning up, you can now also take the membrane and you can roll it up into the syringe and then put the citric acid solution around it and then let it sit there during the case, and it melts. And then you can inject it like this video. And you can see that. So now you can do that also, put it in an 18 gauge or hook it up to a cannula and inject it down the joint or down the peroneal tendon sheath.
That bonds to the tendon, and it makes, like, we've had so much less scarring and such. It's amazing.
Yeah. So, all right. I apologize for the technical difficulties that I can never seem to escape.
Great talk. No worries.
That's great. Yeah, we appreciate hearing, and that's cutting edge. I mean, it's like, I feel like I'm doing a little bit less, especially for small peroneal tears, doing the tendoscopy. You can kind of look and see, hey, is the SPR, like compromised or whatever, and I'm making smaller incisions. Greg, are you guys doing that over in Reno or what have you?
Yeah, we'll do it if patients, I'll do it basically if I have a low suspicion that there's a peroneal tear, just to confirm. If I think that they have a tear, usually we're doing something else for them anyways. And so it seems like, opening up and taking care of it makes sense. But I think it's a nice diagnostic tool if you're not, or in my hands, if it's something you're not super worried about. I think the problem with like subtle instability is, as you examine a lot of patients, there's enough patients that if you get them to bilaterally dorsiflex and evert, some patients will just perch up over the end of that fibula bilaterally. And so I think it's really hard to tell based on just evaluating one side if that instability is legitimate or just an anatomic variant.
No, I agree with you. And Kirsty, like over in San Francisco, where people are always like, in San Francisco. So it's like, hey, my ankle is snapping. What do I do? Like, how do you approach that? Sort of like, ultrasound, what have you.
Yeah, I mean, similar to what Kreulen was saying, I mean, we orthopedists don't really do ultrasound too much. But we actually have a really good group of colleagues in our musculoskeletal radiologist department that are super highly specialized just on doing musculoskeletal ultrasounds and musculoskeletal injections. And so for diagnostic evaluations, a lot of times we'll send them to specific people that are just really very highly trained and expertise on the ability to diagnose those things. And what I do is I just write down, please evaluate for a peroneal tendon subluxation. And I just had a patient come back saying they're not subluxing, but they're snapping within the sheath. So they're skilled enough that they can actually see those things. And if we're worried there's a tear, they can inject them with a little lidocaine. So luckily we have that in our kind of armamentarium to use as our allies.
No, I think that's that's kind of what has, we used to be like, oh, MRI looks okay. And I think that's a great point. Like using ultrasound, seeing whether or not there's this like subtle, subluxation, and it's a great point. And I don't do ultrasound either, but I'm sure around the world and here in the US for other people who are watching, that's kind of like one of those things where you say, hey, send it to your colleagues over there who are doing ultrasound and move to the next spot. So good points. And Gregg, let us know what happens when we open this stuff. That's next.
Can you guys see that okay?
I'm seeing it.
Perfect. All right, so peroneal tendons, what to do. I'm at Reno Orthopedic Clinic, and Reno, Eric and I are co-directors of our fellowship. We've been friends for a long time. I'd like to thank Selene Parekh for putting this on. It's a great conference. Eric for putting this together as a panel and his good friendship and letting me steal some pictures from him. And then of course, all the panelists, it's a privilege to be here with you guys. So peroneal tendon tears, as you know, are a significant cause of lateral pain. They're oftentimes associated with an injury or underlying anatomy. And the tears can be splits or tendinosis or ruptures. And so really, I think the first thing that you need to ask yourself is, how did this patient get this injury? So was it a severe ankle about it related to ankle sprains? We're not going to go into this in any real detail, but it's really important to evaluate all the causes of pain related to an ankle sprain. So that would be an OCD, lateral ligament instability, painful os trigonum, deltoid, spring ligament, posterior tib. All of the different myriad of problems that we see with ankle sprains need to be addressed and evaluated before you focus on the peroneal tendon tears. If a patient has cavus foot, of course, this is a common cause for peroneal tendon tears and tendinopathy. Oftentimes, these patients have recurrent ankle injuries that can lead to the peroneal tendon tears. And with cavus, there's this variable severity. So the patient on the right, for instance, has mild cavus, where the patient on the left has more severe cavus. And so here's a case for the panel. So this is a guy that came down to see me from the lake. He's 53-year-old. He's really active. He had worsening lateral pain, really with no specific injury. He had a remote history of previous ankle sprains, but has done well up until recently. And so I ordered an MRI, and on the MRI, you can see he does have a little bit of evidence for tendinopathy, particularly just behind the malleolar groove, and then more distally. So on a guy like this, which one of you, how would you guys address this? Would you guys address this cavus deformity as part of this?
Gregg, I think it's a great, it's a great question. And so these are these things that we say, like, how old is he? You know, like if this were a college athlete, like, you know, on a panel, like this is a college football player with a scholarship, or, you know, we're around the world here, so it's proper football. So, you know, would you do this? I would just fix his perineals. But if this is like, you know, 40-year-old dad trying to like still play basketball, you may correct his hindfoot deformity. Kiersey, what would you do? I mean,
I guess he's 55. I would also just make sure he doesn't have subtalar arthritis, because some of the people I see with kind of chronic instability and varus develop some subtalar arthritis. So I just fixed a guy, and you know, he was told he needed a shift, but actually ended up having some subtalar arthritis. So I think I'd make sure that that's not playing a role in his pathology as well.
I think that's a great point. Kreulen, this is a rugby player that you're taking care of. What would you do, mate? Kreulen, come in. But all right. So
Sure, move on. So I tend to be a little bit more aggressive. And if I have somebody who has any type of peroneal tendon pathology and they have a cavus, I'll address the cavus, because I think the cavus is really why they got where they are. And I think if you don't fix the cavus, I think you're just more likely to set them up for a repeat injury of those peroneals. So I tend to be a little bit more aggressive. They really have peroneal pathology. I'll fix the cavus.
I think that's a good idea. I mean, it's hard because it's hard to tell a patient, like, they're like, hey, it hurts out on the outside of my ankle. And they're like, well, we got to shift your heel. We got to, you know, and then we got to do a metatarsal osteotomy, but that's probably what's best for them.
Well, I also tell them, you know, if you don't correct the underlying pathology or problem, then, you know, they're just going to continue to re-tear their tendons. And that's, I think, the real problem that we see is if you don't address the deformity, then it doesn't matter what you do to the tendons, they're going to continue to degenerate. And so I think, especially a person in their 50, 55, you know, they have a long while to live. They're not in their 30s as an athlete, and they're not, you know, 85. And I think in that stage, I think people are reasonable and they don't want to have to undergo serial or sequential surgeries with long recoveries. So I think, you know, I think it's worthwhile to have the discussion. I mean, I always have the discussion with them. And I think most of them tend to be reasonable after they kind of think about it and realize they don't want to have to undergo further surgeries in the future if they can potentially prevent it.
I agree. I think that, you know, these perineal, like in a cavus foot, and I'll ask Kreulen, like, what I always stress about, and what, I mean, Greg, this is great. This is a great slide right here. Like, the night before this, I lie awake at night saying, like, the cavus foot always is big enough so that you can make 2 incisions. But what about this MIS stuff? I mean, Kreulen, are you doing, I've now been like, I'll use the MIS burr, so I don't even have to worry.
Agreed. Yeah, I look back at some of my wound complications of trying to do perineals, or maybe even stretching that incision to get the calc slide through one incision. And now that I'm comfortable with MIS, it's just a, you know, 5 millimeter incision, and you're done, and you don't have to worry about a significant soft tissue bridge if you need to address other lateral pathology. So MIS has really changed things. You can be very aggressive. You can do a Dwyer without really worrying about it. So that's changed a lot. And I agree, you got to correct everything. Otherwise, they're going to keep coming back.
And I agree that you certainly can do MIS if you have that capability. I think that you're also safe, really, as a general rule, to do 2 incisions. And I've been doing 2 incisions for years. And for the most part, patients have done pretty well. So but I agree. If you've got access to MIS in the skill, then certainly is one less thing to worry about. Another consideration, if you're going to be in there and you've got some perineal pathology and patients have a prominent tubercle, I'll take my incision a little bit longer and I'll take out that tubercle like Eric showed. It can be prominent. It can be a cause of of pain. So I think if you're there, it's worth excising. So the acute peroneal tendon dislocation, Dr. Giza brought that up. Oftentimes it's associated with a sprain, but not always. It's usually some type of resisted eversion dorsiflexion injury that causes a tear of this SPR. Patients will show up with pain and swelling over there. You might see this flex sign on the radiograph, but not always. And then patients may or may not give you a popping sensation. And as Kirsty had mentioned, there's lots of reasons for popping, whether the tendons are snapping because there's synovitis back there. I've seen split tears of the brevis where the longest splits in and out of that. So you really have to be mindful about what could be going on regarding peroneal dislocations. And again, on the left side, this is how the acute patients show up, and on the right side is how the chronic ones show. And this shows the peroneal tendon sitting over the lateral side of the malleolus. So this one's a much more obvious example. Then if you get an MRI and you're lucky, you might see something on the MRI that's going to give you that diagnosis. So for instance, here, the peroneal tendon is actually on the outside of the lateral malleolus. Over here, you can see that perching over the surface of the lateral malleolus. And on the far right side, you can see that elevation of likely that labrum on the insertion of the SPR. So if you take them to the operating room, this is sometimes what you'll see, where the pickups are grabbing the SPR and it's just elevated off of the lateral malleolus. And so you have this bald spot where the tendons have been chronically elevating that off. And so discussion for the panel is how's the panel fixing these?
I think the best thing to do is place an anchor or two and roughen up that bone, but I would place an anchor near the edge of the posterior lateral malleolus and suck that tissue back down, and then pants over vest that with the more posterior tissue of the actual sheath over the tendons.
Yeah, I definitely think that you need to suck and imbricate the SPR down. I tend to do it actually through drill holes. I think you could do it through anchors, I'm sure too, but I do it through drill holes, and you need to imbricate that so it shortens, and then the pants over vest, just like Kreulen was saying. But yeah, I just tend to do it through drill holes.
I agree. I think that's good comment from everybody. I mean, and we're Kreulen and I are at this university where like we can use anchors, ad nauseum, and but around the world, which is what we're dealing with, and then private practice, and Dr. Olson makes a great point. It's like you can do that through drill holes, you can do whatever, but you have to make sure that this whole area, especially when it's been denuded off the distal fibula, that it comes back down. Otherwise, it'll fail. So something to really tack it back down.
And
I
how
also
are
agree, it tends to be really smooth sometimes when they've been dislocating. So you definitely have to roughen that edge up so it heals down when you when you do that pants over vest further imbrication.
And how are you guys managing dislocating peroneal tendons? Are you doing fibular groove deepening osteotomies? Are you doing soft tissue repairs? Are there indications for one or the other?
Well, Greg, don't spoil the case discussion.
All right.
I'm not a groove deepening. Because of the sports fellowship, I feel like you have to so if you have a bank card, right, you have to put it back up, and so that's my philosophy. But let's see.
Okay, we'll move on. So
Gloves off.
I'm a groove deepening guy, and it's just because in my hands it's worked well, and I think it's a pretty easy procedure. I just do a drill hole underneath the fibrocartilage, and then use that drill to shave out the bone until I get right to the fibrocartilage, and then I cut the fibrocartilage and tap it down. and then I'll do a pants over vest repair over the top of it. There was a group, this ESCA APHIS, and I'll refer to this again, this consensus statement, that they still at this point still were recommending fibular groove deepening osteotomies as a treatment for it. But I know, and there's people on the panel who I think are very capable surgeons that have good results, do not do this and do well. So I think that this is still a point of debate. Is there one that's better than the other, or is it just you do what you can do well and then move on? Then thinking about other causes of pain, I think that this was brought before. There's low-lying muscle bellies, and there's accessory muscles as well. And these need to be considered as other avenues of pain other than a peroneal tendon tear when you're in there. And we talked about MRIs already. The MRIs really should not be relied on for peroneal tendon tears. I only really find MRIs helpful if the peroneal tendon looks bad. If it doesn't look bad, then I don't really use MRI. I use more of my finger to tell me whether it hurts or not, and whether there's pathology. And then same thing with ultrasound. There's some good results in the literature for ultrasounds, and like Kirsty sounds like a great avenue for ultrasound for hers. I do not, and so I don't really use ultrasound. And I think that it's really a great avenue for diagnosis if you have the right hands and the right person evaluating it. So do you guys have we talked about this earlier, do you guys have a diagnosis of choice? I think we kind of already touched on this.
Well, we did. I mean, I think a lot of times with these, like, especially if you're in a situation like we are, like we have a lot of orthopedic trauma surgeons, God bless them. And they use these posterior lateral plates, and then you cannot get an MRI because I mean, and Kirsty, I mean, you guys at UCSF, it's a huge trauma scenario. Like they come in and they're hurting. Are you ultrasounding them, and you're just like, whatever, we'll open it up and we'll take the plate out?
No, I mean, if there's a question, sometimes we'll also inject. Like I was saying, we also have the musculoskeletal folks that can and do a diagnostic injection. But I mean, I'm taking out one next week. I mean, it's our trauma guys are incredible. They're great, but they do a lot of posterior plating, and so sometimes we just end up taking out. And then when we do, we just evaluate the tendons at that time. And then it allows you the ability to get an MRI in the future if they still have pain or problems, like if you think they have an OCD or something like that too.
Perfect. All right, Greg, go on. So tenodesis.
That says that if there's more than 50% of it gone, that you should do a tenodesis. And there's also very good results related to repairs and patients being able to get back to their pre-injury state. And so when you have a tendon that looks bad, you also have the opportunity, instead of doing a repair, to actually do an excision where you're removing the section that's painful. So to the panel, because there's very limited literature supporting resection versus repair versus time to tenodesis, this paper again lean towards tenodesis if it's over 50%, but they acknowledge the little bit of data there. So I guess the discussion for all of us would be, what do you guys do for these tears? When do you repair them? When do you resect them?
I think, Chris, we were in Chile when when Emilio Wagner.
Yeah, the Wagner brothers published an article that was looking at the strength. It was cadaver tissue, but they got up to 66% of the tendon diameter being removed, and you still maintain the strength. So basically, even our other friends, Christian Ortiz, Manuel Pellegrini, they have switched to much more resection than repair. And I've kind of followed in that path. And I also like it because now I'm not leaving a big wad of suture within this area to help promote even further scarring.
Great.
So we have a question a little bit along those ways, but about the subluxation. if you had a 35-year-old female who had peroneal tendon subluxation in a normal ankle without any complaints, are you going to chase that just like you chase some of these? So that, and do you also chase some of these tears if they're asymptomatic?
No,
No for both?
no for both.
I
Well-
agree with Gregg Lundeen.
I think it's, I mean, these are always these things. They're like, is this the 35-year-old like trail runner, person who says, hey, look, I got snapping, it bothers me. And then that's a different story. And then we'll ask Ursina because, you're in San Francisco. So
No, I mean, I feel like a lot of people come in with a brevis tear and they have no pain anywhere near that, and they all of a sudden become very concerned that they need to have their tear fixed. And so I think just like Greg talked about in the literature shows, Giza did some of these studies that show that when you have these peroneal tendon tears, they're not always symptomatic, and a large portion of patients are asymptomatic, or there's just an overread. So most of the time I'm guiding people away from fixing things that aren't broken. So for me, if it's not hurting them, I tend to tell them leave it alone.
good. All right, that's a great comment because it's hard because sometimes patients are.
Yeah.
Greg, what's next? And we got to move on. We're probably running a little behind time.
This is it. So then it just had to do with rehab, immobilizing, getting them moving. I tend to let people weight bear pretty much out of the gate, and I get them moving right away.
Yeah, I think the era of putting them in casts, that's crazy.
Yeah, I feel like peroneal tendons in particular can get really adherent and stuck down. And then it's very hard to mobilize them. So I tend to try to move all of these people earlier than later because I just feel like they become very adherent to the sheath and surrounding structures.
Agreed. All right. Next, we're going to the extremes. So, Kirsty, take it away.
All right. So this will kind of lead off of Gregg's talk about more severe tendon tears here. So, all right. So, so I was just going to discuss more of the chronic kind of severe peroneal tearing, and do we really do anastomosis or do an allograft in these really almost unreconstructible or irreparable tendons. So again, kind of historically, there's really a lack of consensus in these severe tears that involve over 50% of one and often even both, because sometimes the primary repairs are unsuccessful. So, classically there have been talks based on the transverse width, dividing them into less than 50% or greater than 50%, whether we try to repair the tendons or whether we try to do a tenodesis. And so then Meyerson kind of expanded this to include the longest, and then started involving more excursion as a possibility, meaning are these tendon muscle bellies viable? So, when Giza and I were talking, the thought do we do this allograft, or do we do a tenodesis, which has kind of been the classic tried and true for these tendons that really are not able to be repaired and actually are really have become really degenerated? Or do we do a tendon transfer? Again, the literature is really sparse regarding this and based on kind of these retrospective limited case series. So, what do we do? Cases for tenodesis, in the literature has been supported by the more recent review articles showing that over 50% the cross-sectional surface area, the debridement repair is more likely to reproduce a poor result. The thought is, and I know maybe this has been kind of, as you guys mentioned, put into question, but the thought is, does it weaken it enough mechanically, or is it just continued degeneration that causes pain from the scarring? So their review has shown that it is still the favored and most common solution due to the relative ease of the procedure and the use of native tissue rather than cadaveric specimens. Additionally, these clinical and functional outcomes have shown that there's, after a 2-year follow-up in this cohort of patients, there's fairly good clinical outcomes with really no difference in strength, concluding that these transfers serve as still a viable option, and without compromising strength or range of motion. In this specific article, they talked about their surgical technique, which is where they actually implanted the longus into the base of the 5th metatarsal. So then the question is, with their described technique, is this just restoring more of a native biomechanics to their, as compared to their contralateral extremity, by having the longus then overtake the function of the brevis after the transfer? So, the folks that are in the tenodesis corner feel that it's still really a viable option, as we've been doing it for many years. But it's assuming there is one healthy tendon, and in the sense of these subtle cavovarus deformities, as Greg showed earlier, sometimes these tendons can kind of wear and become both worn and torn. And is it functionally acting as a brevis if you actually transfer it into the base of the 5th? Or also with larger tears, is there too much scar tissue to the surrounding sheath, as we've mentioned? So I think, we've talked about it, that some people have called into question the ability of the tenodesis to restore the native biomechanics. So then looking at people who are in the allograft reconstruction boat, due to the fact that, does this then more adequately use this intact proximal muscle excursion, where the thought is, can we actually use that muscle that is still functioning instead of tying it to the next muscle? So the thought is, does this reduce scarring? Can it avoid the donor site morbidity and create this more anatomic reconstruction? So then again, as Kreulen mentioned recently, Pellegrini, they looked at this cadaveric study to try to evaluate tenodesis versus allograft loading at 50 and 100%, looking at these two different scenarios of the tenodesis versus the allograft reconstruction, and really thought that maybe that allograft reconstruction was more effective in restoring the normal tension and more closely mirrored the native biomechanics than the tenodesis. So the clinical results were also reviewed in this retrospective cohort, looking at a pretty large intercalary allograft of about 10 centimeters, and really found also that the strength significantly improved as compared to their preoperative, and really didn't see a lot of the complications I think that we're concerned with no re-ruptures. A lot of them returned, or I should say all of them returned to their preoperative activity level. So they really felt this allograft reconstruction can improve strength and yield these satisfactory outcomes with really avoiding some donor site morbidity. And so then kind of where do we go from here? Again, as Greg had recently mentioned, the consensus statement came out on these peroneal tendon pathologies. What they tended to recommend was ideally a single stage grafting, and they recommend autograft over allograft due to the concerns of tissue availability, creep, incorporation, disease transmission. I think, at least in our mind, that the availability, the creep, a lot of those things have been somewhat not as applicable to us, because they have these now preloaded, pre-stressed tendons, and we don't feel like there's a huge concern for disease transmission or tissue availability. Interestingly, they did actually recommend allograft reconstruction over tenodesis, again, to avoid the biomechanics and balance of the foot, which was based on that study that we just mentioned. And if tenodesis is indicated, largely the peroneus longus to brevis was preferred over the opposite, again, trying to continue to restore the natural biomechanics of the foot. So our algorithm really is, if you have these irreparable peroneal tendon tears where they're, pretty severely degenerated. If you have a healthy muscle belly, you have adequate excursion, then we consider using an allograft. Whereas if you really have poor excursion, we feel like the muscle is not functioning adequately, then we consider tenodesis. Whereas if there's really fat atrophy of the muscle belly, then we figure that's worthwhile bringing in another new tendon. So here's just a couple of cases I just wanted to show. So that, we see this is a patient of mine, an 80-year-old retired emergency medicine physician. He had, 6 months of pain. Really after a while, he could only walk a fourth of a mile, and he had failed conservative measures and was unable to get an MRI again because he had an old pacemaker. And so after going in, his brevis was completely ruptured through the sheath proximally. His longus was thickened but completely degenerated with a huge os and a large tubercle. So when we're considering both of these irreparable tendons, I think that interestingly still had excursion. I ended up actually doing an allograft for him and kind of put it between his proximal brevis and longus, and then reattached it to his brevis. And actually he's doing quite well. I mean, it's short-term follow-up. But the other case I just wanted to demonstrate, because I'm sure you guys have seen a lot of these, but we also see these kind of crazy, really degenerated tendons. This is a 70-year-old engineer I saw who had kind of an old basketball injury, and he had his prior repair was using this horse pericardium like 15 years ago, and had years of pain, could only stand for 30 minutes eventually. And, if you can see his MR, he has all these little tiny, I'm sure everyone can see, little slips of tendon in this big scar ball. So going in there, it was actually difficult to even figure out what tendons were there. It was completely adherent to the sheath. So in these irreparable tendon cases, where there was barely anything available, we ended up kind of doing these allografts. And so, the talk is kind of like, well, they're very difficult. There's still multiple options. And I just kind of showed our algorithm. And so I think allograft reconstruction still is an option to restore this if their muscle belly is viable. So thanks.
Thanks. Thank you, Dr. Olson. I mean, that's kind of, the progressive thinking, and appreciate your insight, and also our fellow Dr. Neary,
Yes,
appreciate you adding all that. I mean, it's never like one of these, especially for us who are doing these, these tendon cases. So I'm going to share my screen, and I appreciate all that insight, because here we go. What do we do? And I know Dr. Parekh's like, all right, come on, get on it.
You got 8 minutes, but
I got 8 minutes. All right. So I'll whip through a couple of the cases. So much experience with our panel. I am going to give you just a quick from our sponsor. If no one's used this hydrogel implant from VersaWrap, Dr. Kreulen and I have started this, and Dr. Parekh, we're writing IRB. This is if you guys can see here, this is a hyaluronic acid membrane that you can put over the tendons, and we've found we'll skip past all the stuff, but I had this 44-year-old person who came to me from very intense, like I run ultra marathons, I got to do everything, and she had one of these peroneal dislocations, and we used this membrane afterwards. And I know people use amniotic membranes, what have you, but we did a SPR repair, And I've found that this really works well. So, and Dr. Kreulen already presented a lot of this stuff. We usually do these injections beforehand. But I really want to know, and this is because my good friend from Dr. Gumai from Japan presented this, that the groove deepening does not matter, and all that matters, X, is doing this. So, all right, I'm going to stop here, and I'm going to just ask the panel real quick. Dr. Lundeen, would you groove deepen this fella? I mean,
Yes.
that's snapping. You would, Dr. Kreulen, groove deepening?
I would open it up and evaluate it. If I can get them to be sitting in their position without sliding off, without me touching, then I do not do groove deepening anymore. I would just fix the perineal sheath.
Dr. Olson?
Yeah, I would do a groove deepening.
You would, okay. All right, so they had a convex posterior fibula, and I didn't do it. All right, next. And Dr., Mike Coughlin, who we all are very, the three of us, four of us are all very, we think, he's a wonderful person. He thinks that the low-lying brevis is not actually pathologic. It's just part of the world. So when you see a low-lying brevis, do you debride it? Dr. Olson first.
Yes, I do debride it. I know he does not think it's pathologic, but the problem is I feel like anything that overstuffs the sheath right at the edge where the brevis is being pressed against the fibula, whether it's a accessory quartus or whether it's a low-lying muscle belly, it may be anatomic, but anything that presses that tendon and narrows the sheath, I am going to debride because I think it helps their symptoms. So it may be anatomic, but I'm going to debride it. Yeah.
All right, Dr. Lundeen.
So I mean, they've always, their entire life, they've had a low-lying brevis, right? So something happened at some point recently to have them come and see. So I inherently don't think it's hugely pathologic. That being said, if I'm in there and I can't find anything else, I'll debride it out, but I don't always debride it out. Like if they have a split tear, I'll usually just take care of that and I'll leave it.
Dr. Kreulen.
I have pretty much stopped debriding it, but I agree with Kirsty. If you're just trying to buy a little more real estate, especially since I don't groove deepen anymore, then I'll remove it.
All right. Low-lying brevis, I groove deepen this one. As much as I say I don't, I do. All right. We saw how Dr. Lundeen did it. We don't have a lot of time. I actually make like a little wedge and just pump it in. All right. We got cyclists. Okay. We know they're not the easiest people to take care of. And Dr. Olson, you live in San Francisco, so everybody's a cyclist, a runner, what have you. And they come in and they say, God, it hurts over my, not here, but just down here. And then they got this big old, pain, etc. You're like, you've been riding for years. Why does it hurt? What are you going to do with this?
Well, I mean, if they obviously have failed conservative measures, I will shave that down while I'm in there, because I do think that it can cause a lot of irritation to the longus, especially, in, like you guys were talking about, that zone 2, definitely can give people longus pathology and tears. So if I'm there, I'm definitely going to shave that down for sure.
And I did, and I actually scoped it as Dr. Kreulen showed, but then of course I opened it. But it made it so it was a smaller incision. So, and then the question would be, Dr. Lundeen, would you, once you open this and shave it down, as Dr. Olson said, would you like put sutures in there, or would you just let it fly?
Let it fly. I put bone wax over so I take out the tubercle and put bone wax over it and then just let it fly.
All right, I obviously put some sutures in there. Dr. Kreulen, I know we are in the same institution, and we don't worry about an extra implant. What would you do?
I would do what Lundeen does. I might not even use the bone wax, but I would just get it out of the way and be done.
All right,
Those are up.
A hook like that. All right, so we got to move on. All right, nanoscope. We already talked about this. Little lateral swelling. And this goes back to our time in Chile. This was from Dr. Ortiz. If you are in there and you're doing a scope, because Dr. Kreulen, you presented the scope and you saw hernias coarseus, which we did, and this is from Chile, would you take it out? Would you not take it out?
I think if they're symptomatic, I would take it out. One thing I want to add about the arthroscopic
Insertion.
Sorry. All right, go ahead.
One thing I want to add about arthroscopic is there are people with tendoscopy that are doing SPR repairs arthroscopically. I know that Eric and I once did it at an ANA meeting. I have not done it on a patient, but there are people who are doing more and more. And so tendoscopy, I think, is going to really move along in technology and skill sets for a lot of people in the next 10 years.
Yeah, and making a minimally invasive incision. All right, Dr. Olson, I got this one for you. You got a nurse at your hospital who's a tennis player. And I know we only have 30 seconds left. She had a pop right here. And this is peroneus longus.
Yeah. Awesome.
Midfoot pain. And what would you do? Like it's broken and then you get in there. Would you repair that or would you anastomose that?
Anastomose it. You can't find the distal stump.
Yes. And that's hard to find.
It's under the foot. There's no way you can retrieve it. I just anastomose it.
Dr. Lundeen?
Anastomose.
Kreulen?
Anastomose.
All right.
Cool.
I repaired it. I put a graft in there and then I put this Alifair, thing on and we'll see. All right.
Awesome.
I know we're out of time. So,
Yep.
And
thanks. Hey, Eric, thanks for that awesome session and the faculty. That was fantastic. A lot of insight. Hopefully you guys got a lot of pearls from you. Thanks for taking the time tonight and I appreciate it. Thanks to Alifair Biosciences for sponsoring that session. We'll see you in the next minute.
Take